Thank you, everyone, and welcome back to the ACIP meeting. We will now move on to the second session of the morning on dengue vaccines, and we have Dr. Wilbur Chen, who is chair of the dengue vaccine work group, providing an introduction and overview of today's session. Thank you.
Thank you so much, Dr. Lee. Let's go to the next slide. So let me remind you about dengue viruses. There are four serotypes. Infection with the first infection confers infection to that first infection, that serotype. But what's concerning is when you are to get a second dengue infection with a different serotype, there's a major risk for having more severe dengue complications and disease. Dengue is the most common mosquito-borne virus globally, and this is concerning. Next slide. Dengvaxia was reviewed and approved, and we have recommendations from last year, February 2021. Trials were done showing that, I think I'm going to the next slide, sorry, that clinical trials were done with Dengvaxia and demonstrated that children without prior dengue infection had a higher risk of hospitalization in severe dengue, which is really the point that I want to make about that second infection. Whereas children with previous dengue infection were protected from hospitalization and severe dengue when they were vaccinated with Dengvaxia. Next slide. Next slide. So the ACIP has reviewed these data about Dengvaxia and had a full recommendation in June of 2021. That recommendation stated that Dengvaxia should be given to children and adolescents 9 to 16 years of age who had established laboratory confirmation of prior dengue virus infection and who dwell in endemic areas. Next slide. So the dengue vaccines work group has convened because we're now reviewing a new dengue vaccine from Takeda called TAC-003. We've presented on this Takeda vaccine twice to the ACIP in October 2022 and February 2023. And during those meetings, we reviewed dengue epidemiology, reviewed the Dengvaxia kind of progress, the ACIP recommendation, and then we had Takeda present on the safety and efficacy of TAC-003, and we also presented the work group's interpretation and the summary of those data. Next slide. So today we have four important presentations. We have a presentation from Dr. Hernandez, who is going to introduce the policy questions surrounding TAC-003. Dr. Spagna is going to talk about a cost-effectiveness analysis and health impacts of this vaccine. Dr. Cowell is going to provide a summary of two economic models of TAC-003. And then finally, Dr. Wong is going to give us a partial evidence recommendations framework for TAC-003. Next slide. The plan is that by the October ACIP meeting, we'll be able to present the full ETR framework, a draft recommendation, and we hope to be prepared for a vote. This is pending licensure. We expect that licensure may be at some point in Q3 2023. Final slide. Really want to thank the members of the work group. I think we under-recognize how much the CDC co-leads and all the other people that are involved with putting together all the information for our work group meetings. Really want to thank them, our consultants, our ex officio members, all the CDC contributors. Thank you so much for putting all of this information together so that we can have these cogent presentations. Thanks you very much.
Thank you, Dr. Chen. And we'll move on to the presentation by Dr. Hernandez on introduction of policy questions for TAC-003.
Good morning. So I'll be introducing the policy questions for TAC-003. The policy questions are framed in terms of population, intervention, comparator, and outcome, also known as PICO. So I will briefly introduce the rationale for the choice of PICO questions for this specific vaccine. We formulated PICO questions based on the directness of the data and then the risk-benefit differences for subsets of the population. For directness of the data, we evaluated 2 age groups based on Takeda's proposed submission for FDA approval, which is 4 to 60 years of age. Next slide. For persons aged 4 to 16 years, data from phase 3 randomized controlled trials with a 57-month follow-up were available. Next slide. And for persons aged 17 to 60 years, only immunobridging data was available, which determined non-inferiority of antibody titer ratios 1 and 6 months after receiving 2 doses of the TAC-003 compared to persons aged 4 to 16. Of note, persons aged 17 were not included in trial or immunobridging data. However, the work group decided to include them in the immunobridging group for completeness. Next slide. So given the differences in the data available by age, we developed PICO questions for each age group. Next slide. For risk-benefit differences, the work group evaluated serotype-specific efficacy by serostatus, given our previous experience with Dengue. Next slide. TAC-003 was not efficacious against hospitalization for dengue 3 among seronegative vaccine recipients compared to placebo, and the VE point estimate was negative, as shown here. Next slide. In the trial, a slightly higher proportion of vaccinated seronegative participants infected with dengue 3 were hospitalized compared to placebo. This difference was not statistically significant, and the overall risk of hospitalization was low. Next slide. However, the work group considered the data was insufficient to rule out an increased risk of hospitalization among seronegative vaccine recipients infected with dengue 3. Next slide. So as a result, we developed PICO questions by serostatus. Next slide. And PICO questions developed include people living in endemic areas only. Next slide. Recommendations for travelers will be addressed by the work group after the October 2023 ACIP meeting, and recommendations for travelers will require separate evidence to recommendations framework. Next slide. So I will now go over the PICO or policy questions. Next slide. So 1, should 2 doses of TAC-003 be administered routinely to seropositive persons aged 4 to 16 years living in dengue endemic areas? Next slide. 2, should 2 doses of TAC-003 be administered routinely to seronegative persons aged 4 to 16 years living in dengue endemic areas? 3, should 2 doses of TAC-003 be administered routinely to seropositive persons aged 17 to 60 years living in dengue endemic areas? And finally, should 2 doses of TAC-003 be administered routinely to seronegative persons aged 17 to 60 years living in endemic areas? And please note that recommendations for seropositive individuals only will require pre-vaccination screening for previous dengue virus infection. Next slide. And to conclude, this table presents the data elements used for each of the subgroups identified by the PICO questions. So in the following presentations, we will discuss cost-effectiveness analyses, vaccine efficacy and safety, and immunobridging. Thank you.
Thank you very much. Next, we have Dr. España. Okay. Dr. España should be presenting on the cost-effectiveness analysis of health impacts of routine vaccination with TAC-003 dengue vaccine in Puerto Rico. And Dr. España, you're from University of Notre Dame. Please go ahead. Dr. España, we can't hear you yet.
Oh, sorry, the microphone was off.
Perfect.
Am I able to share my screen?
Yes, we can hear you now. Thank you.
Okay, so I'm going to share my screen then and go over the presentation. Okay. So good morning. I will be presenting our study on economic analysis and health impacts of routine vaccination with TAC-003 dengue vaccine in San Juan, Puerto Rico. This work was developed by me and my colleagues, Manara Kozweni and Alex Perkins at the University of Notre Dame. These are my conflicts of interest and disclosures. Some terminology used in this presentation include VCD for biologically confirmed dengue, VE for vaccine efficacy, dengue for dengue virus, and the others listed here. So to address the policy questions, we modeled 6 different scenarios of vaccine rollout. The scenarios were defined based on the age groups and the requirements of pre-vaccination screening. The age groups were split into 3 categories: 4 to 16 years old, 17 to 60, and 4 to 60. In terms of the requirements of screening, we simulated scenarios in which pre-vaccination screening was a requirement to determine the serostatus of the individuals, and scenarios without pre-vaccination screening. We focus on 3 groups of the outcomes to determine benefits, harms, and costs. Namely epidemiological outcomes, health outcomes, and economic outcomes. Epidemiological outcomes included medically attended cases and hospitalizations. Health outcomes included QALYs gain, and economic outcomes as the incremental cost-effectiveness ratio per QALYs gain and hospitalizations burden. We used a previously validated agent-based model of dengue virus transmission, and we calibrated this model to reproduce patterns of force of infection, serotype circulation, and age-specific incidence. Our model is stochastic and spatially explicit, with people and vectors moving in ways that represent the reality in San Juan in Puerto Rico. Our model uses a synthetic population to simulate daily activities and interactions of humans and mosquitoes, and then we match overall patterns of serotype distribution so that we obtain a balanced circulation of serotypes. But we also simulated alternative scenarios where we have dominant serotypes in the projection period. And we use 30 years of estimates for the force of infection and data to reproduce the observed transmission patterns. Given that the model is stochastic, some of the outcomes that we show here are a range of possibilities. And we model, as I was saying, dengue transmission for 30 years in San Juan. And then for the projection of 10 years, we sampled the level of dengue virus importations based on the calibrated distribution of dominance. But we also allowed the model to mechanistically reproduce the dynamics of serotype distribution based on other factors like seroprevalence or the level of imports. And the figure here shows dominance by year and an overall dominance in the simulations. Our model and estimates of seroprevalence showed that around 40% of 9-year-old children had been exposed to dengue virus at the beginning of the projection period. This is denoted here by the red asterisk and also by the dashed line at 0.4. I would like to note 2 important factors of this figure. First, less than 30% of children between 5 and 9 years of age were seropositive. And second, that by age 2020, 75% of people would already have at least 1 infection with dengue virus. And we simulated the coverage of the vaccine based on the vaccine rollout from previous introductions of HPV vaccine in the US. Vaccine coverage gradually increased from 0 to around 43% coverage by the end of 10 years. We also simulated alternative scenarios where the final coverage was half or twice the baseline coverage of the vaccine. And in this figure, you can see the black line shows the fit curve of the vaccine coverage with the data shown as the red points. And the blue and red curves show the alternative scenarios of either half or double the coverage. And based on the trial results, we made assumptions of the vaccine efficacy and the vaccine protection. And we assumed that the mechanism of protection was specific for serotype and serostatus for both virologically confirmed dengue and for hospitalizations. And to interpret the trial results, we used a separate multi-level Bayesian model that estimated the vaccine protection. This is a different model for vaccine efficacy that explains the observed efficacy using all the observations to infer the value for serotype. For seropositive participants, the model represented here by orange reproduces the vaccine efficacy estimates at 57 months from the phase 3 trial results, which are represented here by the blue colors. Should note that there isn't enough empirical evidence for some of the efficacy values of 100%, for instance, dengue virus 3 and 4. So we don't expect our model to match these estimates. Similarly, the model reproduces the overall patterns of vaccine efficacy for seronegative individuals. And for this group, the point estimate of the vaccine efficacy against virologically confirmed dengue is negative for dengue 3 and dengue 4, and against hospitalizations also for dengue 3 and partly for dengue 4. And for vaccine efficacy against hospitalization with serotype dengue 3, our model estimated a negative 30% of efficacy, whereas the trial data suggested a negative 88% efficacy. Our model estimated also 39% efficacy against dengue 4, which is contrasted to the 100% by the trial results. To summarize our assumptions, protection from vaccine varies from serotypes and by serostatus. Duration of protection depends on serostatus. We assume an equal level of protection against infection and disease-given infection. And in the scenarios where we implemented pre-vaccination screening, the coverage of testing equals the coverage of vaccination in the scenario where there is no screening. In those scenarios with pre-vaccination screening, individuals can be tested multiple times on an annual basis and can be vaccinated if they eventually test positive. And finally, we simulated outcomes of disease and hospitalizations over 10 years with vaccination compared to contrafactual scenarios without vaccine. In this section, I'm going to summarize our epidemiological outcomes from the model, which are defined as virologically confirmed dengue and hospitalizations averted. In terms of symptomatic cases averted, the strategy without pre-vaccination screening resulted in a higher proportion of the total cases averted when it's compared to the strategy with screening. For instance, in the strategy with 4 to 60-year-olds, if the baseline scenario had 100 cases, 9 cases would be averted without pre-vaccination screening, and 7 would be averted with pre-vaccination screening. The higher benefits without screening are partly explained by the higher coverage of vaccination in that scenario. In terms of hospitalizations averted, no screening also resulted in a higher proportion of the total hospitalizations averted overall. However, for the younger group of 4 to 16-year-olds, which is represented here in the left side of the figure, the number of hospitalizations averted was the same with and without screening, in which case, for instance, for every 100 hospitalizations in the baseline scenario, 3 hospitalizations would be averted with and without pre-vaccination screening. Because of the negative point estimates of the vaccine efficacy for some serotypes in seronegative individuals, we also estimated the harms of vaccination as the additional hospitalizations caused by the vaccine. And to understand the magnitude of these outcomes, we report here a relative measure of harm defined as the ratio of averted hospitalizations to additional hospitalizations. I should highlight that these additional hospitalizations only occurred on seronegative individuals who received the vaccine and who were later infected with either serotype dengue 3 or 4 after vaccination. And in general, in the scenarios that included pre-vaccination screening, the ratio of averted to additional hospitalizations was higher than that of the scenarios with no pre-vaccination screening. This ratio was higher for the age group of 17 to 60 years of age, where you can see that it increased from 35 to 1 in the ratio of hospitalizations averted to 102 hospitalizations averted for every additional hospitalization. And overall pre-vaccination screening results in lower harm according to this measure. And finally, I'm going to present a summary of our economic analysis. To estimate the cost effectiveness of the interventions, we estimated the incremental cost effectiveness ratio for QALYs in terms of QALYs gained and hospitalizations averted. This is presented here in the equation. And we use disability weights estimated from Zeng for the quality adjusted life years gained with these interventions. To determine the cost of the intervention, we assume a baseline cost of $150 per vaccine dose, and with an additional $15 for the administration for each dose. And all costs were estimated for US dollars for 2022. Overall, we found that the incremental cost-effectiveness ratio was higher for scenarios with pre-vaccination screening. This is displayed by the fact that testing requires additional costs, and the number of cases averted also decreased for most of these interventions. However, this wasn't the case for scenarios in the group of 4 to 16 years of age, where the aggregated number of hospitalizations averted was the same with and without pre-vaccination screening. And also considering that younger age groups have a larger proportion of people seronegative, it makes more sense to implement pre-vaccination screening in this group in the simulations, because there is a larger proportion of seronegative individuals who could be exposed to dengue 3 or dengue 4 after vaccination. In summary, our simulation showed some benefits from vaccination in terms of symptomatic cases and hospitalizations averted. These benefits depend on the serostatus of the vaccinees and the circulating serotypes. Pre-vaccination screening reduces the potential negative outcomes in seronegative individuals. And in the ICERs, in terms of quality gain and hospitalizations averted, were higher when implemented pre-vaccination screening, except in the group of 4 to 16 year-olds, where screening was more cost-effective, and cost-effectiveness of the intervention depended on the seroprevalence in the projection period, which it's lower for younger age groups. Finally, there are multiple limitations with our approach, and I just want to make clear that our model projections are not predictions for this period on the serotype circulation or the burden of disease. These are scenarios. Our results on the benefits and cost effectiveness of the intervention depend on these characteristics of the circulation of serotypes during the projection period. And also for the economic analysis, we are not including quality loss due to death in the cost effectiveness analysis. Thank you. I have some references here.
Thank you. This presentation is now open for questions. Dr. Lear?
For the last slide, you did not include the QALYs for death, and I'm just wondering why you didn't. Was there a reason I'm not thinking of?
Sorry, I don't know if you could hear the question. Maybe could you repeat the question in the mic, Dr. Lear?
Thank you for the presentation. On your last slide under the summary, you said that you did not include the QALYs from death in consideration of the economic consequences, and I'm wondering why you didn't include those. Thank you.
Yes, this was an early decision, and we can update it definitely for future iterations of this analysis. In the beginning, the number of deaths were very low and very stochastic, so it added a lot of noise to our estimates. And based on the low number of deaths that do occur in the region being simulated, we decided to not include it for this version of the analysis. However, we can update these estimates, and we have some preliminary estimates of the deaths that are caused and averted, but it's a very stochastic process, and it has a lot of factors that I think were including more noise to the model, so that's why we partly decided to keep them off the analysis early on.
And thanks, Dr. España, for that explanation. This is Dr. Josh Wong here. I'll be presenting the partial ETR a little bit later. Just also wanted to give a little bit of context for that, which is that in this trial, there were no deaths associated with dengue. So modeling of deaths would need to be based on previous knowledge of dengue outcomes. But as Dr. España said, we are working to sort of get those numbers together for our work group to review during the summer. Thank you.
Thank you. Dr. Paling?
Yes, thank you, Dr. Espana, for this great presentation. I just wanted to emphasize a point. And so I think it was slide 38, which was the economic outcomes by scenario from the societal perspective. And so what I wanted to emphasize was in areas where, like San Juan, where dengue is endemic, about 40% of children at 9 years of age will have had dengue. And so in that scenario, pre-screening is cost-effective and improves the outcomes, where in older age groups, where the vast majority have had it, that is no longer necessary. Is that correct from your analysis? Thank you.
That is also a similar interpretation to what I give to these numbers. In general, we tend to see that the lower the age and the lower the seroprevalence, the more cost effective it gets to add pre-vaccination screening. But the cost effectiveness of that intervention is not as cost effective in older ages when most of the population has already had one or more infections.
Thank you. I have a question about, I'm typically used to seeing some type of sensitivity analysis as, following the ICER estimates. And so just wondering, did you do any sensitivity analyses? And the reason I'm asking is because I was wondering in the back of my mind about the seasonality of dengue and the various types that might be circulating in any given season and how much that influences the cost effectiveness estimates.
Yes, we have several sensitivity analysis and alternative scenarios that we have simulated. And we, in particular, we have scenarios of different levels of serotype dominance in the projection period. And I think what was expected and what we have observed is similar that when serotype dengue 2 is dominant, then it's more cost effective than when serotype 3 and 4 are dominant, for instance.
Okay. And are there any other variables which are influential in your model?
Yes. Several. The one of those is, for instance, with the vaccine coverage, which we also have a sensitivity analysis over this. We have different parameters that are related to transmission, and that would result in changes in the epidemiological dynamics in the projection period, And those are most of the parameters that we have focused. For instance, scenarios with higher force of infection or lower force of infection, scenarios with higher coverage or lower coverage, and different profiles of the vaccine in terms of if we just use the trial numbers or if we use our model estimates for the interpretation of the trials, for instance.
Okay, thank you. Any other questions? Thank you very much for presenting. We will move on to the next presentation, which will be a summary of 2 economic models for dengue vaccine TAC 003 use in Puerto Rico. And we have Dr. Call from CDC who will be presenting.
Thank you. Good morning. I will be presenting a comparison of the economic models submitted to the dengue work group, and I'd like to point out that this is a presentation of preliminary results. I'd also like to acknowledge the efforts of the 2 modeling groups. Throughout the presentation, I will refer to the Notre Dame CDC model as the Notre Dame model for brevity. Oh, I'm sorry, next slide. Oops. I'd also like to thank the members of the Dengue ACIP work group, in addition to my colleagues in ISD, especially Andrew. Next slide, please. I have no conflicts of interest. Next slide, please. Here's a list of abbreviations I will be using in the following slides. I would also like to note that all numeric values have been rounded to 3 significant figures. Next slide, please. So my plan for today is to start with the PICO questions and their connection to the models, followed by a comparison of the model results and assumptions, before returning to the Takeda model and then tying everything back to the PICO questions. Next slide, please. So the PICO questions are broken down by age and serostatus. So age and serostatus will be important attributes for the dengue vaccination model summarized here. Next slide. Which these models have handled very differently. The Notre Dame model is able to implement vaccination for a range of ages with or without pre-vaccination screening and can increase vaccination coverage over time to match what is typically seen when a vaccine is first introduced to market. The Takeda model is designed to incorporate routine vaccination at a single age with the possibility of a catch-up routine in the first year. The model does not incorporate pre-vaccination screening. Vaccine coverage can increase for the first 4 years. However, I will mainly be presenting scenarios that look at an increase over 10 years. This is incorporated into the model by using the average value of vaccination coverage over that time of interest. Next slide, please. Vaccine efficacy varies in a few ways. First, the method used to estimate the VE mean differed. Notre Dame used a multi-level Bayesian model, while Takeda model used a more traditional method, which estimated VE from observations in the pivotal clinical trial, except for negative estimates. In those cases, a VE of 0 was used, meaning Takeda's approach removes the possibility of vaccine-enhanced disease from the model. Second, only the point estimate was used in the Takeda model, while the value used in each simulation of the Notre Dame model was drawn from the 95% confidence interval around the mean. Next slide, please. The geographic ranges also differed, with the Notre Dame model using a population size roughly 10% of Takeda's. And finally, dengue-related deaths were not included in the QALYs for the Notre Dame model. To put this in perspective, there were 68 deaths reported in Puerto Rico from 2010 to 2020. Moving on to the most appropriate model scenarios to answer the PICO questions. These are the preliminary results for the first age range in the PICOs, 4 to 16-year-olds. You can see how the geographic range impacts the number of vaccinated, despite the rates being similar. Given this difference, it is fair to compare the percents rather than the absolute averted outcomes. The percent of averted cases, hospitalizations, and deaths is higher in the Takeda model. Next slide. I'd also like to point out that the pre-screening scenarios cost less to improve the same amount of health when vaccination was considered among children and adolescents. Next slide. Moving on to the second age range, 17 to 16-year-olds. Again, you can see how the geographic range impacts the number of vaccinated, and the percent averted cases, hospitalizations, and deaths is higher in the Takeda model. Next slide. However, unlike pre-screening in the 4 to 16-year-olds, pre-vaccination screening in 17 to 60-year-olds range costs more to improve the same amount of health. This is reasonable given the seroprevalence increase with age, and VE is higher in those who are seropositive at vaccination. In all cases, vaccination improves the health of the population, but the model comes to different cost conclusions. Let's look at some differences in the model assumptions. Next slide. So starting with quality loss, which has been converted to quality adjusted days lost, I want to bring your attention to the NAs. The Notre Dame model does not include fatalities in the calculation, and they also do not explicitly account for persistent symptoms. Next slide, please. When the days lost for roughly a third of patients over 30 with persistent symptoms is incorporated into the Takeda values, the days lost increase. However, they are still lower in the Takeda model. Next slide, please. The next difference I want to cover are the VE values used in the models. This is a dense table, so I'm going to walk through the columns and rows before showing you the data. So first, VE is dependent on serostatus at vaccination and the infecting serotype. Next, both models include VE against symptomatic cases and, next slide, hospitalizations. All right, adding in the values, next slide. Thank you. As mentioned earlier, the Notre Dame model sampled the VE from the 95% confidence interval around their point estimates for each simulation. The Takeda model used the point estimates based on the pivotal clinical trial, except when the value or the confidence interval included negative values or locked observations. Next slide, please. In most cases, the point estimates are comparable, except for cases infected with dengue 3 or 4 and were seronegative at vaccination, which is highlighted in gray. In this case, the Notre Dame model allowed for negative VE values to be used or vaccine-enhanced disease, while the Takeda model used a value of 0. Next slide. We can explore the impact of the VE assumptions by only replacing the VE values in the Notre Dame model with those of Takeda's values, and then comparing those two results. So in this case, looking at vaccinations in 4 to 16-year-old population without screening, the Takeda VE estimates had a slight increase in the mean in the mean number of averted hospitalizations. But when looking at the range of outcomes, which is in parentheses, the results were not sensitive to the specific VE used. This indicates that the VE assumptions alone do not explain the differences in these models. Next slide, please. All right, so we've explored some of the differences. Let's switch gears to reviewing the Takeda model. Next slide, please. Takeda's base case used a routine vaccination at age 8, with coverage ramping up to 60% in 4 years and then holding at 60 for the remainder 20 of the simulation. Here we see that around 1/5 of the hospitalizations and deaths are averted with vaccination, and it is cost savings with a bit over 2,000 QALYs gained. Next slide. Since we are interested in vaccinating a range of ages, we can add the catch-up vaccination to year 1, which almost doubles the number of vaccinated and also doubles most outcomes, with the exception of the number needed to vaccinate to avoid 1 hospitalization. Both scenarios are cost savings. The second scenario, without routine vaccination at 8, with a catch-up from 9 to 16, is the most applicable to the PICO questions. Next slide, please. To summarize, we can look at the different scenarios on a cost-effectiveness plane as orientation. The incremental costs are on the y-axis, and the health outcomes measured as QALYs are on the x-axis. Both models predict that health will be improved with vaccination. All of the points are, meaning that all the points are on the positive or right side of the x-axis. In terms of costs, the models are fairly different. The Notre Dame model predicts that societal costs will increase, positive y values, and the Takeda model predicts that costs will decrease, negative y values. So zooming in on Takeda's results for a moment, next slide. Because health is improved and the societal incremental costs are negative, the Takeda model predicts cost savings. The difference in the model's total number of QALYs gained is expected given the several assumptions. So the Takeda model assumes a larger population size and projects a higher absolute number and percentage of cases averted. In addition, the Notre Dame model allows for vaccine-enhanced disease and does not include QALYs from death. Both assumptions reduce the health impacts measured by QALYs. Based on the results not presented, changing the assumptions can make the models closer, but the underlying factors for these differences across models and the impact of each assumption on the final model results are still being investigated by the economic review team, and we look forward to providing an update at a later meeting. Next slide, please. I'd also like to keep the limitations in mind while weighing these preliminary results. So first, there are large uncertainties around the seronegative at vaccination VE against dengue 3 or 4. This is important because the effectiveness of the vaccine is serotype dependent, so the realized outcome is heavily dependent on the dominant circulating serotype. The decision to leave deaths out of the QALYs in the Notre Dame model could have a large impact since deaths can occur in younger individuals. And finally, Takeda's model is unable to assess the benefits versus risks of the vaccination with respect to vaccine-enhanced disease. Next slide. This is especially important if the recommendation does not include pre-screening. And next slide. And again, I'd like to acknowledge the contributors to all of this work. Thank you.
Thank you for that presentation. And thank you for sharing the information around parameter uncertainty. I think that's really helpful and also very intuitive. Are there any questions for Dr. Call? Dr. Paling.
I just wanted to take a moment to say thank you. The cost-effective analysis are really important and complex, and the way you can present so we understand how you legitimately can come to very differing perspectives is really important. And so I just wanted to say a thank you for helping us reconcile how various analyses came to different estimates. Thank you.
So I also just want to echo my thanks. I have to say, like, in general, our CDC colleagues, number one, do this very intensive review of all the economic models, both their own as well as the industry models. And then providing the comparison in this efficient way, I think, is incredibly helpful to the ACIP members. It used to be a series of much longer presentations, and you've done a great job making it efficient. I will ask, some of the comments you make in the limitations are fairly important, so my assumption is that this will come back for presentation to the committee with updates once the final review is complete?
Yes.
Okay, thank you. I don't see any additional questions right now, so let me get my glasses on. All right. Are we ready for Dr. Wong, everyone? Who will be going over the partial ETR framework for TAC 003. So I'm assuming this is part 1 and part 2 will come later. Dr. Wong, are you on the line or are you in the room?
I'm on the line here.
Okay,
and
terrific. Thank you.
Yes, there
The
will be
floor is
something
yours.
afterwards. And give me just one moment to set up my screen sharing here. Great. Is that showing now?
Yes, we see your screen.
Oh, excellent. Okay. Well, thanks for having me and good morning. I'll be presenting a partial evidence to recommendations framework for TAC 003. And before we started, I wanted to be clear about the goals of today's presentation, which are to summarize the extent of the dengue workgroup deliberations and present 3 of the ETR domains, and also to prepare ACIP for the next meeting, at which point we intend to present a full ETR, a recommendation, and a vote. So the full ETR will summarize the domains that I present today with relevant updates, and will also include the workgroup opinions and straw polls that I will not be presenting today. So please consider this presentation info only, but while you're listening, we'd appreciate if you could identify any specific data or areas where you would like more information to help inform our summer workgroup deliberations. So of the 7 ETR domains that you see on this slide, I'll be presenting 3 and include the public health problem of dengue, the benefits and harms of the intervention, TAC 003, and the domain of resource use. So let's start with the first domain, which asks us to consider if dengue is of public health importance. And as Dr. Hernandez discussed, all 4 of our policy questions at the moment focus on populations living in dengue endemic areas. So according to the Yellow Book criteria, there are 6 jurisdictions with endemic dengue, including the 3 freely associated states of Palau, the Federated States of Micronesia, and the Marshall Islands, seen in blue at the top of this slide, and the 3 U.S. territories of American Samoa, Puerto Rico, and the U.S. Virgin Islands, seen in green at the bottom of this slide. In the 3 territories with endemic dengue, there's a total population of 3.4 million people. And Puerto Rico has a population of 3.3 million people, or about 96% of the total population at risk. In October 2022, Dr. Adams presented these data from the 3 US territories by year from 2010 to 2020, with Puerto Rico in pink, American Samoa in blue, and USVI in green. Among the more than 30,000 cases reported, most came from Puerto Rico. However, when we look at the incidence per 1,000 persons, we can appreciate that rates were similar in USVI to Puerto Rico in the early 2010s, and that the outbreak size in American Samoa from 2017 to 2018 had high disease rates for the population size. So now let's focus on the burden in the 4 to 16-year-olds, the age group of interest to the first 2 policy questions. So looking at the dengue case counts in the bars with the axis on the left and the hospitalization right in the dotted gray line with the axis on the right, we can see that these are highest in the 10 to 19-year-old age groups, highlighted in the yellow box. This is also true for American Samoa and USVI. I will note that USVI in green on the left has vertical axes for both case counts and case rates, which are proportionally smaller compared to American Samoa in blue on the right. This reflects the high disease rates per population size for American Samoa. However, the trend remains the same for both, in that 10 to 19-year-olds highlighted in the yellow boxes have the highest burden of cases and hospitalization rates. But despite this burden in children and adolescents, 2 of our policy questions ask about adults. So for adults, is dengue a public health problem of importance? And this figure shows the 68 fatal dengue cases in Puerto Rico for the same time period by 10-year age groups. Even though the burden of disease and hospitalization is in younger groups, this figure clearly shows that most of the fatal cases occurred in adults older than 20. So to summarize this part, dengue is endemic in 6 US territories and freely associated states with the largest population at risk in Puerto Rico. The highest case and hospitalization rates occur in the 10 to 19-year-old age group, and the highest mortality rates occur in adults greater or equal to than 20 years old. So later this summer, our work group will reflect on these data and select from the options seen below to answer this question. So now let's turn our attention to the benefits and harms domain. And the first question I want to discuss within this domain is, what is the overall certainty of the desirable anticipated effects, and summarize the grade analysis, because it informs the way our work group is thinking about all the issues unique to dengue vaccines. For the grade analysis, we identified 4 desirable outcomes that are critically important to decision-making, which are virologically confirmed dengue, or VCD, hospitalization for dengue, dengue hemorrhagic fever, and severe dengue, all due to any serotype. Now, when Dr. Hernandez and I conducted the systematic review, we found 370 articles, of which 17 included these outcomes of interest. However, none of these articles contained the 57-month data stratified by our policy question populations that's the most appropriate to making a recommendation. So thus, all the data we used comes directly from Takeda's presentations to ACIP and our work group. Because all of these data came from Takeda trials, the grade analysis, which contains all the domains seen here, was greatly simplified. The domains in the red boxes with arrows did not raise any serious concerns for the certainty assessment and were the same across all the outcomes. However, there were differences in indirectness and imprecision by population and outcome. So it was these 2 domains that determined the final certainty assessment. So let's start by reviewing the certainty of the evidence in the 4 to 16-year-olds for whom we have phase 3 trial data. And to do this, I want to quickly review the highlights of the work group interpretation of the efficacy data that was presented in February. So we saw that overall, for protection against VCD, we have positive point estimates for VE with 95% confidence intervals that do not cross 0 in seropositives on the left or in the seronegatives on the right. However, when we look at individual serotypes, we see that in seropositives, it protects against all 4 serotypes. In seronegatives, it only showed protection for dengue 1 and dengue 2. We also saw a similar effect for the outcome of hospitalizations. It protected both seropositives and seronegatives when you aggregate the data for all serotypes. However, stratified by serotype, it protects seropositives against all 4. but only protects seronegatives against dengue 1 and dengue 2. Not only did the work group conclude that there was no efficacy against hospitalization for dengue 3 in the seronegatives, but they also concluded that the data were insufficient to rule out an increased risk of hospitalization. And for the outcomes of dengue hemorrhagic fever by the 1997 WHO definition on the left, and by the more specific trial definition for severe dengue on the right, there were so few cases overall that while the work group concluded that it offered protection for these outcomes in seropositives on the left of the flow diagrams, there was no efficacy seen in the seronegatives on the right. Additionally, it was difficult to draw any conclusions on protection by serotype since there were so few events per serotype. For instance, there were fewer than 10 events per serotype in either the placebo or vaccine arm for seropositives for the outcome of DHF. And there were fewer than 5 events per serotype and per arm for seronegatives for the outcome of DHF, and for both seropositives and seronegatives for the trial-specific definition of severe dengue. So despite the uncertainty by serotype, we looked at these outcomes of interest aggregated by serotype, because looking at evidence for 4 outcomes by 4 serotypes in 4 populations would be inefficient and impractical for recommendation making for a single tetravalent vaccine that can't be divided into 4 monovalent vaccines. So based on what I just described, you can appreciate that when we look at the VE by aggregated serotype data, the VE had a confidence interval that did not cross 0 for all outcomes in seropositives and for VCD and hospitalizations in seronegatives. However, the confidence interval did cross 0 in the seronegatives for DHF and severe dengue, which were downgraded for imprecision. But how do we deal with the significant differences in VE by serotype? And for that, we have to look at the domain of indirectness. And so when you pose the question, does the study population differ from the population of interest? The differences by serotype become a clear concern for directness. In the large phase 3 trial by Takeda, the most common serotype circulating is seen by the case counts of VCD in the placebo arm were dengue 1 and dengue 2, biasing the VE outcomes for all serotypes combined towards the VE for these 2 serotypes. However, in Puerto Rico, we've had circulation of all 4 serotypes as seen in this figure, showing the proportion of cases attributed to each from 2010 to 2020. In 2023 alone, we've had local transmission of 3 serotypes and cannot predict which one of these will ignite and dominate the next epidemic. So since our population is at risk for all 4 serotypes, we can say if there's at least one serotype for which there's no significant protection, that the VE for all serotypes combined observed in the trials would not directly apply to our population, because you wouldn't expect to see the trial observed VE in an outbreak dominated by a serotype for which we know there's no or lower protection, like dengue 3 and seronegative vaccinees. Or put another way, the VE for all serotypes combined observed in the trials could only be expected to reflect the true effect if there's significant protection against all 4 serotypes. So applying this criterion to our PICO groups and the previous data, we found no serious concerns for indirectness for VCD and hospitalization in seropositives, but downgraded the certainty for these outcomes in seronegatives and for DHF and severe dengue in both seropositives and seronegatives. So looking at the final certainty assessment, we have high certainty and are very confident that the true effect will be close to the trial effect size for all serotypes combined for VCD and hospitalization in seropositives. We're moderately confident for protection against severe disease in seropositives and against VCD and hospitalization in seronegatives, though there is the possibility that the true effect could be substantially different from the trial. And we have low confidence for the severe outcomes in seronegatives, for which the true effect may be substantially different from the trial results. Now let's turn our attention to the certainty of the evidence in adults, starting with seronegatives. As Dr. Hernandez already noted, this was assessed through immunobridging data. Takeda has presented the data in this table to our work group, showing the geometric mean ratio of the titers in 4 to 16-year-olds in the phase 3 trial compared to the 18 to 60-year-olds. As you can see in the blue rows at the top, which are the GMRs by serotype at 1 month after second dose, and then the green rows below those showing GMRs 6 months after second dose, almost all of the GMRs met the non-inferiority objective. Use of immunobridging data is the classic example of indirect evidence, so we downgraded the certainty of the evidence once. As such, we have moderate confidence that the VE seen in seronegative children in the phase 3 trial will be close to the true effect in seronegative adults, but with the possibility that it will be substantially different. For seropositive adults, we have to infer the VE from the immunobridging data in seronegatives. Now, Takeda only conducted the immunobridging trial in seronegative adults, since the serotype-specific titers in seropositive children and adults following vaccination would be confounded by the serotype of their past infections. So for this data, we assume that seropositive adults will have immune responses at least as robust as seronegative adults. However, given that the data for this group assumes an equal or higher immunogenicity compared to seronegative adults, which in turn infers efficacy through a surrogate measure, we downgraded it twice for indirectness. Certainty for VE in seropositive adults is low, and the true effects of TAC-003 may be substantially different from the effects seen in children. So these certainty assessments, along with the vaccine efficacy by outcome and by PICO group, are summarized on this slide, which are available after this presentation. But to summarize the summary slide, for all the desirable outcomes, we found high to moderate certainty of the evidence in seropositive children and adolescents, moderate to low certainty in seronegative children and adolescents, moderate certainty evidence in seronegative adults, and low certainty evidence for seropositive adults. So now that we've established the certainty of these effects, how are we thinking about quantifying the desirable anticipated effects? So in addition to age and serostatuses recommendation for vaccination, the population level effects are strongly influenced by population seroprevalences and the serotype circulating. And that's why Dr. Espana's presentation has been so helpful in assisting us with thinking through these situations. And as a quick reminder, his model assumed a seroprevalence of 40% by age 9 and vaccine coverage increasing from 0 to 40% over the 10-year time horizon for all eligible individuals in that age group. And then he described the overall reduction in VCD and hospitalizations due to dengue for the entire population of the municipality of San Juan. And as previously detailed by Dr. Espana, the distribution of the serotypes in his model was based on decades of data from San Juan and includes circulation of all 4 serotypes. So his model found a 1% reduction in VCD and 3% reduction in hospitalizations when TAC-003 was recommended for seropositives 4 to 16 years old. A 3% reduction in both outcomes when recommended for all serostatuses 4 to 16 years old, a 6 and 10% reduction when the recommendation is for seropositives 17 to 60 years old, and an 8 and 13% reduction when the recommendation is for all serostatuses 17 to 60 years old. And while those population level estimates describe the impact when recommended for each PICO age group, either for only seropositives or for seropositive and seronegatives, we can also look at the impact of a recommendation by serostatus for the entire age range included in the phase 3 trial and the immunobridging trial. And so for seropositive individuals from 4 to 60 years old, he found a 7 and 12% reduction in VCD and hospitalizations, and a 9 and 15% reduction when recommended for all serostatuses 4 to 60 years old. So to summarize his data, his modeling shows a reduction in VCD and hospitalization when TAC-003 is implemented in all of the populations that are explored in the policy questions. And those reductions are higher when the vaccine is implemented in the 4 to 60-year-old age ranges and without pre-vaccination screening. These data, along with a review of the absolute benefits scaled up for all of Puerto Rico, will help our work group answer the question of how substantial are the desirable anticipated effects. Now let's look at the undesirable effects and answer the 2 questions of how substantial are the undesirable anticipated effects and what's the certainty of that data. So the undesirable effects that are of critical importance to decision-making are the 2 traditional vaccine-related safety outcomes of serious adverse events and death. Data for these outcomes is from pooled data from phase 2 and 3 trials. And among seropositive individuals 4 to 16 years old, 8.5% of them experienced SAEs in the vaccine arm and approximately 10% in the placebo arm, many of them due to dengue. Deaths were rare, with 0.14% in the vaccine arm and 0.12% in the placebo arm. For seronegatives, approximately 8% had SAEs in the vaccine arm and approximately 9% in the placebo arm. Deaths occurred in 0.05% of both vaccine and placebo arm recipients. And as a note, none of the deaths in the trial were due to dengue, which you can see in the footnote. So we found no serious concerns with imprecision or indirectness for these outcomes as they related to our PICO populations. And as such, we're very confident that the true effect will be close to the trial estimates. And now looking at adults. So for seronegative adults, There were far fewer participants compared to the thousands of children enrolled in the large phase 3 trial, DEN 301. But of these, approximately 2% experienced SAEs following vaccination and approximately 4% after receiving the placebo. There were no deaths in either arm. We found no issues with imprecision or indirectness and gave a high certainty level for this group and for these outcomes. The sample sizes were even smaller for seropositive adults, with only 83 in the vaccine arm and 31 in the placebo arm. So given the sample size is less than 100 in both arms, the work group thought that this posed a serious concern for imprecision, and the final certainty assessment was moderate. So these results of undesirable effects and their certainty rating are summarized on this slide that will be available after this presentation. But to summarize the summary, the certainty of the undesirable outcomes was high for both seropositive and seronegative children and adolescents and seronegative adults, and it was moderate for seropositive adults. But now I want to change gears here and talk briefly about a unique safety consideration for dengue vaccines that doesn't fit nicely into any of these boxes. And that's the fact that all of these outcomes of interest that are on the desirable list, like prevention of VCD and hospitalizations, can also be an undesirable outcome if the vaccine enhances dengue. And in the case of TAC 003, these effects can differ by vaccinee serostatus and serotype. And this unique consideration really fits best under the question of risk-benefit balance. So the specific question posed in the ETR framework is, do the desirable effects outweigh the undesirable effects? And one way to think through this is to subtract the total number of cases of VCD and hospitalization caused from the total number averted, leaving you with a net benefit afforded by the vaccine. And so we're actively working with Dr. Espana and others to review these model numbers this summer. But the other way to think about it is to divide the total number of cases averted by the total number of cases caused by the vaccine. And this approach emphasizes safety and helps decision makers define their own values to think through what minimum threshold cases averted compensates for one additional vaccine-induced case. Dr. Espana presented some of this data to us earlier. And so for vaccination in 4 to 16-year-olds, you avert 6 hospitalizations for every 1 caused by the vaccine under a no screening scenario seen in the green dot. And this increases to 15, the blue dot, if you institute screening and vaccination of seropositives only. The ratio is higher in both scenarios for 17 to 60-year-olds, given their higher rates of seropositivity, with 35 cases averted for every 1 additional case, but increases up to 102 to 1 with pre-vaccination screening. For the combined age ranges, that ratio is 18 to 1 without screening and increases to 69 to 1 with screening. So to summarize these data, we see that in all scenarios, this ratio of averted to additional cases increases with pre-vaccination screening. We also see that this ratio is higher in the older age groups compared to the younger age groups. And when thinking about the balance of desirable and undesirable effects, we'll need to weigh the safety benefits afforded by pre-vaccination screening, the lower overall reduction in VCD and hospitalizations that's driven by depriving seronegative individuals of vaccine protection against dengue 1 and 2, as I showed you in the previous slides. So analyses such as these are an active area of discussion in our work group, and we look forward to sharing their opinions in October. Finally, my colleagues, Dr. Espana and Kaul, have given an excellent overview of the cost effectiveness of TAC 003 and have given more nuanced answers to this question than I can provide. However, I do want to summarize some of Dr. Espana's results regarding the ICERs per hospitalization averted and per quality gain for the 4 populations in our policy question. So the incremental cost effectiveness ratio, or ICER per hospitalization averted and per quality gained, was lowest in the scenario of screening and vaccinating seropositive 4 to 16-year-olds, with an ICER per hospitalization of 16,800 and per quality of approximately 180,000. Notably, the screening scenario in this age group had lower ICERs than in the no screening scenario. The highest cost was in 17 to 60-year-olds, with screening equaling out to $49,000 per ICER per hospitalization averted and $397 per quality gained. In this age group, it was higher compared to a no screening scenario, in contrast to the younger age groups. This also remained true when looking at the 4 to 60-year-olds, where the scenario with screening was a slightly higher ICER compared to the no screening situation. So our work group looks forward to discussing these results further and answering this question on resource use this summer. In conclusion, our work group has reviewed the data for the domains of public health problem, benefits and harms, and resource use. We reviewed the certainty of the evidence for desirable and undesirable outcomes in the populations in our 4 policy questions and found that certainty ranged from high to low, depending on the type of data available, the outcome, and the serostatus. Additionally, weighing the risks and benefits of dengue vaccination is complex, especially given differences in seroprevalence by age and jurisdiction in dengue endemic areas, the unpredictability of serotype dominance in future outbreaks, and the differential VEs by serostatus and serotype for TAC 003. And finally, we will continue discussing these issues to craft a draft recommendation that we hope to present at the next meeting. As a reminder, this was an info-only partial ETR, and any feedback or questions that you have that could shape our summer work group deliberations would be greatly appreciated. I want to thank the ACIP work group for their hard work on this and let the committee know that I also have the dengue vaccine work group co-leads, Dr. Gabriela Paz-Bailey and Dr. Laura Adams in the room with me. So we can now take any questions that you might have regarding this presentation or others. Thank you.
Thank you very much, Dr. Wong, for your presentation, which is now open for questions. Dr. Lair.
Thank you for your presentation. I have one question for you and one question for the general group. The question for you is, I guess I was under the assumption that if you screened and gave the vaccine, that it was unlikely that you would end up having someone go in the hospital. But it looks, according to your ratios, that even if you screen, there still might be some people who are vaccinated who might be going into the hospital because of the vaccine. Is that an appropriate interpretation?
Yes, that is correct. And the reason for that is that screening tests are not perfect. And so there's going to be a specific sensitivity and specificity, but also there'll be a positive and negative predictive value that will change based on the seroprevalence. So in the younger age groups where seroprevalence is lower, the likelihood of a false positive result that leads to vaccination and that eventually leads to hospitalization is higher than at higher seroprevalences. So even using pre-vaccination screening as a strategy, there will still be a rate of false positive results that will get that vaccination. So that might explain some of the differences seen where it reduces the number of additional hospitalizations to prevented hospitalizations, but doesn't bring it down to 0.
Thank you. That's very helpful. And then a general question for the group. I was presuming that this vaccine would actually not be on the recommended immunization schedule. But now that I think about it, these are U.S. citizens, and I don't see a reason why it would or would not be. And I'm wondering, what are the criteria if this would ever be on the immunization schedule? Because if it was, that would mean that it would be covered by the Affordable Care Act.
So the dengue vaccine is on the immunization schedule, the currently licensed one. And it has a recommendation for a particular age group in an endemic area in the United States, or in a United States territory.
So I'm looking at the immunization schedules as they're published. Is it on the children's?
It's on the children's schedule.
Thank you.
And to clarify, the original vaccine was only studied in children and only recommended for children. This is the one we're thinking of a broader perspective. I believe you are correct. It is 9 to 16 is the current recommendation age group.
Thank you. Dr. Brooks?
Yeah, thank you. Excellent presentation. Just 1 or 2 questions. First, one of the slides, the fatal cases in Puerto Rico were 68 over a 10 or 11 year period. So there are only 6 to 7 deaths per year of dengue. This is a very low number of deaths, just noting that. And the other question was, what is the interval, the 2 doses? What's the time frame between the 2 doses?
Dr. Wong, do you want to take that?
Oh, sorry about that. I was on mute. But Yes, saying to your first question, yes, that is correct, that there were only 68 deaths from 2010 to 2020, and that for the interval, it's 0 and 3 months, so it's a 2-dose schedule that takes 3 months to complete. Thanks.
All right, I was just thinking then, is there a risk of giving the first dose and then someone gets dengue between the first and the second and therefore have a more adverse outcome because they got vaccinated and they were seronegative and, had that, issue that we've seen with those that were vaccinated but did not have the disease?
We actually have our colleagues on the line from Takeda. And is there data on interdose efficacy of this vaccine? Because I don't believe I've seen that published.
Yes, so this is Vianet Triku from Takeda, medical director from clinical development. So we do have data on the efficacy between the first dose and the second dose, and they are consistent with the efficacy post-second dose. So it's about 80% for symptomatic dengue. And this efficacy is generated pretty early on after the first dose. So around we see the separation of the curve, of the incidence curve between placebo and vaccine recipient after about 2 weeks.
And one comment that I will just make, is that in terms of being able to detect the possibility of increased risk of dengue between doses during a 3-month period, the negative point estimate that was seen in dengue 3 in seronegatives was had a very wide confidence interval and did have very few cases. So I think restricting even the period of observation to 3 months, would be quite difficult to be able to detect a signal that would be, possibly this low. So, but thank you for the question.
Dr. Long?
Yeah, on the same kind of an issue, it's not just, that is one, interdose susceptibility and outcome. But I think Dr. Brooks was also asking, not everybody gets a second dose on time. So in an endemic area, maybe you spend 6 months, maybe you spend a year. I think what we were asking is, what's the vulnerability for severe or dengue hemorrhagic fever in those who were seronegative who get only 1 dose of a planned 2-dose vaccine?
We don't have data right now comparing the efficacy in individuals with 1 dose or 2 doses. And I don't know if there are any trials that are planned for that. So, I'll ask my Takeda colleagues again if there is a trial planned for that.
No, at the moment, no.
Okay. Well, thank you. Then we do not have that data right now.
I have one question, well, maybe 2, but one is going to be, can you remind us for the Dengvaxia vaccine, whether or not it was serotype specific, for example, serotype 3 and 4, similar to what we see here? And the reason I ask is I'm trying to understand why type 3 and type 4 behave differently than type 1 and type 2 in seronegative patients. And then I have a second question for you.
Sure. The differences between TAC-003 and Dengvaxia are quite different. And particularly, I think, in the study methodologies. So TAC-003 did have serostatus determined at the beginning of entry into the trial, whereas for Dengvaxia, it was sort of a post hoc analysis and a case cohort control study that was needed to be able to determine that level of risk for hospitalization and severe disease. So there are some differences in methodology, but overall, I think one of the big differences between these is that Takeda vaccine for seropositives shows protection against all 4 serotypes. And for seronegatives, it shows protection for dengue 1 and dengue 2. And then for dengue 3, there was just insufficient evidence to rule out the possibility of increased risk. Whereas for Dengvaxi, it was a very different story because for seronegatives, aggregated for the seronegatives, there was an increased risk of hospitalization and severe disease. And then when you stratified that by serotype, there was nothing that was significant in the serotype stratification, but did certainly show, lower or, negative vaccine efficacy for some serotypes over the other. And, some of the theoretical reasons for this could be the backbone on which the vaccine is based. So the Dengvaxi vaccine had a stronger dengue 4 component, whereas the Takeda vaccine was built on a dengue 2 backbone. So theoretically, that could be some of the explanation for the differences in serotype efficacy.
Yeah, I think that information could be helpful, just generally speaking, at the next meeting. And then the other sort of question I had was really, I recognize that we're going to look at the ETR specific to this particular vaccine product. But, similar to as there are multiple products that become available on the market, it'll be helpful to understand where harmonization is appropriate versus where it doesn't make sense. So just having that context might be helpful for the next committee meeting.
Absolutely. And just to correct something that I previously said, but Dengvaxi was built on a yellow fever backbone.
Thank you.
But yes, thanks.
Dr. Long?
Yes, so it's probably a picky question, but it's really hard when you get to implementation and also for us to understand things when age groupings are odd. These are very odd age groupings. So the epidemiology is 10 through 19 shows increased risk of severe outcomes. And the grouping here of what you're going to be proposing and what you're looking at for efficacy and potential adverse events is 4 through 16, and an adult here is at 17. Are there reasons for this in what the background seropositivity is? But it's really hard for us to understand the cut points.
Yeah, thanks for that question. The age groups and the cut points were based on the data that was available. So, the Dengvaxia trials were in children from ages 2 to 16, but then there was increased risk seen in the age group of 2 to 8. So that's why it was recommended for the age group of 9 to 16 with laboratory confirmation of a previous dengue virus infection and living in endemic areas. For the Takeda data that included in their trial were children from the ages of 4 to 16 in the pivotal phase 3 trial. And then the immunobridging data was done in individuals from the ages of 18 to 60. So that's why the groupings are as they are. Thank you.
Thank you. Are there any other questions or clarifications members would like to have before the next meeting? Okay. Well, thank you so much, Dr. Wong, and thank you to all the presenters in the dengue vaccine session. We are going to move to a lunch break here on the East Coast, and we will return at 45 minutes after the hour. Thank you, everyone.